Good morning, ladies and gentlemen. It's about the contribution of the brachioradialis muscle to the radial deviation of Saldaharis two distal radius fractures in school-age children. In the next 8 minutes, I will try to answer the questions if we should pronate it or supinate it, our forearm, after a closed reduction. Let's go to introduce you to the most common fracture in school-age children, the distal radius fracture. It is a fracture that affects more likely men like female. And the range of age in school-age children is about 6 to 14 years of age. The most common type of clinical manifestation is a dinner fork deformity. And the most common mechanism of injury seen is falling back or forwards with the elbow in extension, the forearm pronated, and the wrist in flexion. Events leading to the deformity are likely to be skating, cycling, rolling, falling from high, trampoline, playground injuries, and of course, traffic accidents. You know from the lessons of orthopedics and traumatology that the Saldaharis classification is the most commonly used classification in pediatric orthopedic traumatology. Useful classification in predicting the physical history of the fracture, determining the treating method of choice, if you have to treat this kind of fracture conservatively or surgically, estimating the energy of the injury, if it is high or low energy fracture, and calculating the potential of the bone remodeling if the fracture line is near or away from the physis. Saldaharis II fracture seems to be most often with a radial deviation. The most common type of distal radius fracture is getting along with a radial deviation rather than an ulnar deviation. And the question is, why does it appear with a radial deviation? We know from the lessons of anatomy in the first ages of our medical school that the brachioradialis muscle, a very big and long muscle between the distal humerus and the distal radius, has an insertion site in a styloid process of the radius about 17 to 28 millimeters away from the apex of the styloid process of the radius. He is a flexor of the elbow when the forearm is pronated, and in pronation and supination of the forearm, when in a resistance, he is a pronator and supinator of the forearm. He is innervated from the radial nerve, C5, C6, and his origin is the proximal two-thirds of the lateral supracondylar ridge of the humerus. Very important to recognize that the brachioradialis muscle is contracted when the forearm is in pronation and is relaxed in supination. And you can see here in this picture the correlation, the very high and strong correlation between the insertion site of the brachioradialis and the distal radius fracture. In our research, we studied about 5 months, 20 pediatric patients, 18 males and 2 females, aged 8 to 12 years. And after falling down with a mechanism of an outstretched elbow with a forearm in pronation and the wrist in dorsiflexion, the most common type of clinical manifestation during the admission was a dinner fork deformity, nerve and vascular status was intact, and lack of elbow flexion while the forearm in semi-pronated position. It was not an open wound. The distance that we measured between the top of the radial styloid process and the radial side of the fracture line was measured with X-rays of the wrist. And we used, of course, the profile view and the face view. These are the results of the distances in a in a phase view of the radial wrist, between the apex of the styloid process and the radial side of the fracture line. As you can see, in summary, 70%, that means 14 out of 20 patients that we have examined had a fracture line that was in the area between 17 and 29 millimeters away from the styloid process of the radius. And I tried to draw down all that results using an inch scale ruler. And as you can see, the density of all these fractured lines of all these patients was in the area between 17 and 28 millimeters away from the styloid process, and especially in a distance between 20 and 24 millimeters away from the apex of the styloid process of the radius. Taking into account the anatomy of the brachialis and its effect on the radial deviation in distal radius fractures, we strongly believe that the most suitable form of immobilization should be with the elbow flexed 90 degrees and the forearm in supinated position. We came to that conclusion that the insertion site of the brachioradialis muscle is located about 17 and 28 millimeters from the apex of the styloid process of the radius. Its density is higher, about 20 to 24 millimeters away from the top of the radial styloid process, dorsally and distally. And the brachioradialis muscle is the factor that contributes at most on the radial deviation of the distal fragment of a Salder-Harris 2 distal radial fracture. Due to its relaxation in a supinated forearm, the immobilization of the forearm in supination minimizes the possibility to lose the closed reduction. And last but not least, further studies comparing the immobilization of the forearm in pronation and supination should be done to provide us with more convincing information. Thank you for your attention, and don't forget that simplicity is more than complexity, the ultimate sophistication.